Today, I am here with Dr. Harita Raja. She is a women's mental health psychiatrist, and I'm so excited for this discussion today on women's mental health, perimenopause, and we'll, of course, talk about sleep as well. Dr. Raja, thank you so much for joining me. Can you tell us a bit about what you do and who you serve?
Of course. Thanks for having me. I'm really excited to be having this conversation. So, I'm a women's psychiatrist. I actually only see women and really see women across their life cycle, have a specific focus on hormonal transitions and how to help women with their mental health through that, but really see women across the life cycle.
Yeah, it's so great because we were chatting a bit before we started about the great need for this type of
Yeah.
information, for this type of approach. Women have been underserved with regard to perimenopause or just even across the lifespan, really, when it
Yeah.
comes to understanding things through this holistic lens. And I was watching your Instagram and you had this really great reel showing the DSM-5 and how there's no mention of perimenopause or menopause or hormones in the DSM-5, although hormonal issues are so vital to women's mental health. So we're going to talk about that today. So I'm curious how you got interested in this topic in the first place. Is it something you learned about during your residency, or what brought about this interest for you?
Yeah. I am so thankful that I did get interested in this. And I would say I didn't go into my psychiatry residency really thinking that I would get into women's psychiatry. I actually was really interested in child and adolescent psychiatry, but I would really take that home with me. And so I was like, I need something that I'll take home with me. But as I saw men and women, when you see women and men in such an intimate setting in psychiatry, you're asking really about the most intimate parts of their life. You start to really notice that there's a huge difference between men and women. We're not the same in the ways we think, the way we experience hormonal shifts. And so I just became interested in how is that affecting women? And I was pregnant in my residency, and so really experienced how that was for me while being not only a resident, but also experiencing my own mental health symptoms of having a panic attack out of nowhere for the first and only time in my life, and experiencing some anxiety. And was it clinical anxiety or not? And how did it impact me? And so really that experience of having those symptoms, but also having a women's clinic where I trained at Georgetown to put it together, felt like I really connected with women and could understand where they were coming from. And when they were heard, they really felt like they could let their guard down and really get treatment in the way that they needed it.
So did you end up doing additional training in women's mental health afterwards? Or because I know a question I hear a lot from psychiatrists and primary care physicians as well, but I think specifically psychiatrists is how do we even get that education? Should we even be prescribing HRT? Is that within our scope of practice? So I'm curious what your journey
Yeah,
has been.
it's a great question. And I actually didn't get additional formal training in that I didn't go for a fellowship because fellowships for women's psychiatry or reproductive psychiatry aren't accredited. And so for me, I had to make a decision, how am I going to do this? And it was really by going to conferences, having additional mentors, taking courses. So I did the Menopause Certified Practitioner course. I did courses through Postpartum Support International, which is for perinatal patients, and really having to educate myself. And so for those practitioners out there, I would say it's never too late, right? I prescribe HRT in my practice. I'm probably in the less than 1% of psychiatrists that do. And yet I'm not doing it rashly. I have mentors that help me. And I've talked to my malpractice who have said it's within my scope of practice and I'm doing it for mental health. And so it's really recognizing what women's needs were. And if I didn't do that, I didn't feel like I was giving them the complete treatment option.
That's so great. Yeah. And so let's go into this a little bit more, talking
Sure.
about the role of HRT in mental health and just approaches to women's mental health as a whole. So if you have a patient in front of you, let's say it's a woman in her 40s and she's struggling
Yeah.
with anxiety or panic or insomnia or depression, how do you determine if her symptoms are related to hormonal fluctuations, to perimenopause, or not? What would your general approach be? Because sometimes these sorts of symptoms can be quite nonspecific.
Yeah. I think it's the nuance in the art of medicine, right? So I think for a patient that comes in, I want to know, is this the first time she's experiencing symptoms? Is this something that she's been having before? Her experience in terms of first episode versus not. I want to know if she's having cyclical symptoms or is she having it all the time. So I'm really trying to characterize her symptoms and their presentation. I would ask for other questions too. And so every patient I see, and this is not just in that hormonal time in midlife, but across the board, I'm going to ask them an obstetrics and gynecologic history, right? So I'm going to ask when their last period was. Do they usually get regular periods? Are they having irregular periods? As you and I know, you don't have to have irregular periods in perimenopause before you have symptoms like insomnia or anxiety, right? So we can have these symptoms sometimes before that. But one common thing I actually do see is that maybe their periods haven't gotten irregular, but their flow has changed. There's a different quality to their pain with their periods. Like, just there are these subtle differences. And so really getting a good history and really understanding their period and other symptoms of perimenopause. Are they having hot flashes? Are they having joint pain? Are they getting the word finding difficulties? Being able to have these wide brushstrokes that allow us to paint a picture to understand, is this woman in this time in her life? Two things that I would say common misconceptions are like age and being really specific about age and a lab test. And I'm happy to go into that a little bit more.
Yeah, please. Yeah, if you could share a little bit more about age, because I know I actually saw this comedian on, I think it was on like Instagram the other day, and it was a YouTube short, and she was talking about the fact that doctors will not think about perimenopause until you're 45. She was just joking about this, that, okay, if you go to the doctor when you're 44 and you've got insomnia and joint pain and brain fog, they're like, no, you're depressed. And then the moment you turn 45, they're like, oh, you're in perimenopause. So could you speak to that a bit more? And then the lab testing piece.
Absolutely. We want to put things in a box, right? We want to look at patterns. The problem is that every woman is different when they're going to hit perimenopause. And perimenopause, just to define it for anyone who doesn't know, is really the time where your hormones are fluctuating, but not in that cyclical way. They're becoming much more irregular. And it's before you hit menopause, which would be when you haven't had your period for a year. And so in the perimenopausal period, that's really the more vulnerable time. And the average age for a woman in this country to hit menopause is 51 to 52. Some women are going to have perimenopause 4 to 7 years before. And some ethnicities, we're talking over a decade, right? And that is one important point. So definitely not just 45. That's that marker for us. But I will say some women are going to have early perimenopause or premature perimenopause, which is going to be even earlier. And so this is why we're really looking at the big picture. I know that I hit perimenopausal symptoms even before 40, right? And so if I had gone to a doctor and said, these are my symptoms, and they weren't well-versed enough, they would have told me it's something else, right? And what I might have done is gone to see 10 different specialists for all the symptoms I was having, but really I just needed to be educated on this being perimenopause. And so I think age is really important for us to recognize, like, it helps us get an idea about the picture, but it's not the whole picture. So again, I think a really common misconception is if your labs show that you're in perimenopause, you're in perimenopause. But again, when we look at fluctuating hormones that are irregularly fluctuating, it's just the point in time that we get when you're getting lab tests. And so again, it can help us understand the picture, but it's not going to tell us if you're in perimenopause. So when a woman comes in to see me and says, I saw my gynecologist and she said my labs are fine, or I saw my primary care doctor and he said my labs are fine, I'm not in perimenopause, that's really a time for me to educate, right? That labs are not going to be the gold standard for diagnosing perimenopause.
Yes, that makes so much sense. And nowadays I get lots of patients asking me about labs. Should I get my hormones checked? And even though it's not something that I'm trained in, so I'm not necessarily ordering those labs for them or recommending HRT to them, I do like to refer them to people like yourself who do have that education and training. But patients will ask me, what lab test should I get done? Should I get my hormones checked? What am I looking for? So how would you counsel those patients, especially for the clinician who's listening who doesn't have the training that you have? What should they be telling their patients and clients?
Yeah, I think first and foremost, validating their symptoms, right? Like talk to them about their symptoms, educating them what perimenopause looks like. So if you as a clinician haven't really educated yourself about perimenopause, there's great books out there, articles, podcasts, however you like to consume your information. But then I would say to really advocate for the patient in terms of, let's look at the patient as a whole first. Like your example patient here, 40-year-old woman with the first episode of panic, and her periods are irregular. I don't have to go very far before I know that she's probably in perimenopause here. And again, what do we want to do about that next? Versus like just going to a lab test. And I think that's just, it feels like it's an easier way to go because, oh, we'll get concrete data and that's just not the way to diagnose. So I think really helping your patient understand why. And so I usually take out the graphs of this is what estrogen and progesterone are doing in your body during your monthly cycle, pre-peri, but like in premenopause, which is like before perimenopause. This is what your hormones are doing in perimenopause. And if I just put this time where I've drawn your blood or this time where I've drawn your blood, it's not going to give me the full picture. So helping them understand why I'm saying what I'm saying. Look, we're a society of immediate gratification right now, right? We want to know now or yesterday. And so if someone says, hey, I can check your labs and tell you if you're in perimenopause, it feels like that's the way to go, but really it's not giving us the data we need.
Yeah, and I think it's so helpful to have those graphs. And so I have one that shows the zone of chaos, showing all the, right,
Yes.
all the hormone fluctuations. And I
Yes.
think just as a clinician, just having a few of those on hand, if you have a Google folder, just keep them on your desktop, slides that you can pull up. So if you have a patient in front of you, whether you're seeing them on Zoom or in person, you can show that to them, and a picture is worth 1,000 words, and it makes so much more sense
Absolutely.
to people.
Yeah, absolutely. And I think perimenopause is a really unique time. Like, I think women go in to see their doctors and they just feel like they'll tell them exactly what to do. In perimenopause and menopause, because we're just having this movement now about really understanding it, and not all physicians and other providers understand it is important for us to have to advocate for ourselves. And I think so, as clinicians, you're going to get patients who come in. If you see any women in midlife, you are seeing perimenopause and menopause, guaranteed. But if you don't think about it, it's easy to just attribute it to other things. And so I would say, if nothing else, just consider that this is playing a role with the hormones.
That's so helpful. So we'll circle back to that, and we'll talk about what do you do next with that patient or client in front of you, especially if you're not someone who is trained in treating these issues. So we'll put a pin in that for now. We'll come back to that. But I wanted
Sure.
to talk a little bit more about sleep issues, because that is one of the most common complaints that women have during perimenopause and menopause. And sometimes those are the first signs of hormonal shifts. Can you speak about that? What are some of the common sleep issues that you might see during this time of life? And at what point might those also be diagnostic clues that we're dealing with perimenopause versus a primary anxiety or depressive disorder?
Yeah, so sleep is absolutely one of the common symptoms we see initially. And for me, it's really important to understand like the specifics of the sleep issue, right? And for me, when I am looking to treat the sleep, is what is the root cause? And so I encourage women to really give me a full history to understand what's going on, if they may need a sleep study. And I'm sure you've talked about this before, but a thin woman doesn't mean that she can't have sleep apnea. And a lot of patients that I've sent for sleep studies end up having sleep apnea because, yeah, and they've never been diagnosed with it before. But we know hormonal changes are also affecting sleep. And so I really try to get to the root cause. I'll tell you, one of the most common things I see in perimenopause is that hot flashes are waking up women, but also anxiety is waking up. Anxiety symptoms are waking up women. And so I want to be able to hit that from the root cause, but I really need to have the big picture. And so I would say if it's a hormonal reason, which could be the reason for the anxiety, I would consider HRT initially. If it's just anxiety and it doesn't seem to be hormonally mediated, I would think more of an SSRI or SNRI to do that. And I'm always wary of supplements. I have to be careful. There are a lot of patients want to use over-the-counter supplements, and we really talk about what can be helpful, what's the data, et cetera.
I'm so glad you mentioned the sleep apnea piece, that it can happen in
Yeah,
people of all shapes and sizes, all ages.
absolutely.
Yes. And I saw, as my specialty is sleep, and so I had a few referrals for treatment-resistant insomnia earlier this year, and these were all women in their 40s. And they had cycled through the usual treatments. These were all referrals from psychiatrists, so they had tried the usual Ambien, trazodone, melatonin, all the sleep aids that usually people will try, or even CBTI, cognitive behavioral therapy for
Hmm.
insomnia. And they
Hmm.
still weren't improving. And so they were referred to me for treatment-resistant insomnia, and I did sleep studies on all of them, and they all had moderate to severe obstructive sleep apnea. And sleep apnea looks very different in women than it does in men. I have other videos on that, so if you're listening and you're curious about that, you can go check out those videos. But it is something to have on our radar, and the prevalence increases during perimenopause and menopause. So I'm really glad that you mentioned that.
And it makes sense, right? Because as the hormones are changing and they're impacting at their estrogen receptors throughout our body, that's why there are mental health issues that happen too. We have estrogen receptors in our brain. And so this is where we have really fragmented care. But I am sure that our physical I'm sure our organs change with the decrease in hormones as well related to sleep apnea. And it's unsurprised that women, as they're getting older, are having an increase in sleep apnea.
Yeah, absolutely. And okay, so you're mentioning the estrogen receptors in the brain. So let's talk about that a
Yeah.
little bit more. Could you speak about that? And we'll talk about treatments leading into that as well. But that may be
Sure.
surprising for people who are listening that, wow, we have estrogen receptors in the brain. So, yeah, can you tell
Yeah.
us more about that? As you can see, there's a lot to learn when it comes to clinical sleep medicine, and we're just scratching the surface in today's interview. If you are a physician or a health practitioner who wants to learn more about clinical sleep medicine in a practical way that you can use in your everyday clinical work, then get my free sleep mini course. I'll put the link to that in the video description below. You can also get it at intrabalance.com/doctors.
Yeah, so I'm actually going to show you a book because I have it on my desk and I refer to it all the time, which is The Menopause Brain by Lisa Mosconi. So Lisa Mosconi is a researcher in New York who's done a lot of work in looking at the brain in women in midlife. And she's shown us that there's receptors, estrogen receptors in the brain. And she always tells this interesting story where she went to ask a colleague if we can find the estrogen receptors in the brain, and there wasn't a modality available to be able to do that. So we had to start there. But she had some great images if you want to look online to see the estrogen receptors in the brain, and they're in the median lobe and the temporal lobe, and they're in very important parts of our brain. And so, of course, estrogen modulates serotonin and other neurotransmitters, and that's what impacts. We talk about mood and anxiety and sleep. We can go a little further. We see an increase in ADHD symptoms. We see trauma being re-exacerbated. We see an increase in OCD symptoms. We're just at the tip of the iceberg as we're starting to discuss the mental health impacts of perimenopause and menopause. But the reality is that these receptors are everywhere in the brain. And so we do see a change to memory, attention, cognition, executive functioning that are really related to the hormonal changes.
It makes a lot of sense. And you've discussed this as well on your platform that women will come in saying, I have to read that email like 3 or 4 times because I just can't focus or I just can't remember things. I've had
Yeah.
patients tell me, like, am I developing dementia? I'm having all these issues with forgetfulness. Or I feel like I'm just fatigued all the time. I don't have the energy and stamina that I used to. And I feel like something's really wrong with me, but I can't put my finger on it. Yeah. And so it makes a lot of sense based on what you're discussing here.
Yeah. And there's a lot of fear, right? I'll say one of the most common sort of fearful questions I get from women is, do I have dementia? Am I developing early dementia? And a lot of it comes from their experience, maybe in their family with someone who had dementia, even if it was in later years, just the fear of knowing how it can look, right? And knowing that it's possible that they get that and how distressing and burdensome it was. And so that often comes up. And yeah, there is a change in cognition. And so women are scared for a reason. And I get that. And we know that 2/3 of people with Alzheimer's are women, but yet when in perimenopause, we're seeing cognitive changes, it's not that means that you're definitely going to have dementia. And so being able to talk about that with women and help them understand, like, these are the hormonal changes that are leading to this. And until the hormones stop fluctuating like they do in perimenopause, like, those symptoms may continue, and we can talk about what we can do about it. But the reality is, like, there's a reason for that.
Let's talk a little bit more about treatment. So you've mentioned hormone replacement therapy, HRT. You also mentioned SSRIs and then other lifestyle interventions as well. So for the clinician who has this woman in front of them, let's say it's the
Yeah.
41-year-old woman who's got worsening moods, some depressive symptoms, new onset anxiety, sleep disturbances, having trouble maintaining sleep, and you think, okay, this is probably perimenopause based on her history. What's the next step, especially for that clinician who's not trained in prescribing HRT?
Yeah. So again, I know I keep going to this, but I always talk about education first because it really helps women to understand their option. They have to remember the Women's Health Initiative was a big study that was done in the late 90s and early 2002 was when they stopped the study. And basically the media said, and the report that was given was that hormones are bad, right? Hormones increase the risk of breast cancer, strokes, heart disease, etc. And that made a lot of people scared. So I think we just have to, and there's a lot of stigma with mental health medication, let's be real. And so I think the first step is education. This is what I think is going on. I think this is perimenopause for these reasons. You're at this age, you're having these symptoms, this is the big picture. What can we do about it? These are the options. The reality is that some women are going to need just hormone replacement. Some women are going to need SSRIs, antidepressants, anti-anxiety medication. Some women are going to need both, and some women are going to need neither. It really depends on the severity of their symptom. And so I like to ask women, like, what's bothering you the most, right? So if a woman tells me, like, everything's fine, but really for me, like, the panic attacks are really bad. And that's what bothers me the most. So I probably am going to address the panic attacks first before I get to the big picture, because I need her to feel like, again, she's been heard and validated, and we're going to go down this path with her. But we're going to come up with a systematic plan. I'm not going to show the kitchen sink at her. And of course, I want to weigh my risks and benefits for hormone replacement therapy versus medication. There's just a lot of things I'm thinking at this time. But I would say if there's a perimenopausal component, if you're not comfortable prescribing hormones, knowing the people in your community that are, and I'm going to say, get on my soapbox for just a minute, which is if you think all OBGYNs understand perimenopause and menopause, you're going to be really disappointed. And it's not their fault. It's just the training wasn't there for menopause to be under that umbrella alone. So really finding out who the providers are in your area, who are comfortable with perimenopause and menopause. And you can look at the Menopause Society website, but also just talking with different providers, you'll get an idea. I do prescribe them, so I know when I want to start them versus other medication. If a woman has had symptoms before, again, I want to see how long it's been and what I might need to do next. I will say a lot of women need both for this reason. Estrogen modulates serotonin and other neurotransmitters, meaning that it's going to work with them. So there's really a synergistic effect. And so even if it's the hormonal reason, even if it's perimenopause and the hormonal changes and the fluctuations are causing these symptoms, without the SSRI or another anti-anxiety medication helping, you're really just with partial treatment. And are some women okay with just HRT? For sure. I would say in my experience, it's usually both. And it's a little biased, right? I'm a psychiatrist, so they're coming to me when they're much sicker with the psych symptom.
That reflects what I see in my clinical practice, because I will have women who they're going through perimenopause, they're having all the symptoms that we talked about, and then they go and they get prescribed HRT and they start it and they have an initial improvement. They're like, oh yeah, I feel better. But then the symptoms come back. They start feeling anxious again, or they start having sleep issues again, or they're feeling depressed. And you've alluded to this fact that treatment is very nuanced and that we need to look at it from multiple pillars. It's not that HRT is the cure-all and we prescribe that and everything's fine. We do need to look at it from all these other angles. So I'm curious what else you might recommend in your treatment plan in addition to HRT or SSRIs. What else do you have in your toolbox?
Yeah, I just jumped right to medications, and I really do the lifestyle stuff first, because I think, especially now, women are much more comfortable with it, right? It's everywhere. They're like, okay, what can I do nutritionally? What can I do exercise-wise? So I talk a lot about strength training. And again, because I understand perimenopause and the impact that hormonal fluctuations has on their bone health, right? I tell women, and I really encourage them to get a DEXA scan. I understand I'm a psychiatrist, but I also might be the only provider they're seeing. And so their whole health is important to me. And I'll tell them to get a DEXA scan and really start strength training. But we also talk about, depending on the patient, really the simple things like going outside every day for a 10-minute walk is where I might start with the muddy. I've started at 2.5 minutes, right? Well, we really get to whatever behavioral intervention will work. But we talk about exercise, depending on what the patient can tolerate. We also talk about nutrition. I think there is so much emphasis on weight gain during perimenopause, and women really feel uncomfortable in their bodies, and that can come up a lot. And I talk about nutrition really from the psychiatric perspective of how does it impact your anxiety? How does it impact your sleep? How does it impact your depression? And how does it impact your self-worth and how you see yourself? And so we talk about renormalizing what's appropriate. And what I mean by that, a lot of women, maybe they've had an eating disorder in the past. And so that could get really re-triggered. And we're talking about like the same things you did before aren't going to work now, right? But let's talk about what's really going to work now. So I work with a lot of local nutritionists to help the patient understand what their body needs, and that starving your body isn't helping your body because it's just helping it to hold more fat, right? So really helping women to understand that is important. We talk about other therapies. So some women actually just need psychotherapy. Like you mentioned about CDTI, I use cognitive behavioral therapy for insomnia all the time. And so that is really important. And then I'll use like magnesium glycinate, for example, or I'll use melatonin to help with sleep. Patients have their own supplements that they'll bring to the table, and we'll talk about how it's helped them, if it hasn't, what the interactions might be. But I'm just wary in this time. Look, perimenopause and menopause are probably billion-dollar industries are going to get there really soon. And there are a lot of companies that are just trying to monetize the vulnerability of women. And it's really important for me that if something works and there's data, great, let's support that and help women to understand. And I really do believe that not everything is FDA approved that's going to work. And yet there are other companies that are just throwing out supplements that when women are vulnerable, they're just going to buy and spend a lot of money on. And so it really helps women to understand how supplements can be helpful and how to read the data a little bit more rather than just fall for the marketing. So one of the most important things I like to discuss with my patients that I think isn't discussed usually in physicians' offices is the sense of community. So a lot of women are going through different life changes. A lot of women in perimenopause, unfortunately, may be leaving their career because of their symptoms, having career changes. They may have relationship changes, whether they're getting separated. And some of them are experiencing real changes in terms of their children leaving the home or maybe coming back, just different changes that are really impacting them. And so I really encourage them to find their community and who are they going to spend time with and who's going to support them through this, because it's not meant to be a journey you do by yourself. And I think women sometimes just want to like white knuckle it and they say, let me just do this by myself because there's a lot of shame or a lot of frustration, but really they need the support a lot during this time. And so I will actually talk about studies that have been done, like Harvard, for example, has done studies about the importance of relationships on longevity and health. And so really try to use the data to show this isn't just me saying you should have friends and have a community, but really it is so important for your health. And I think this is a time when women really need to have their women around them. So I think that's one more thing that I definitely talk about.
I'm so glad that you mentioned that because it's one of those missing links in healthcare. And I think as psychiatrists, we may be particularly attuned to the importance of social
Yes.
community and connection, but it's not often discussed. My primary
Yeah.
care doctor has never talked about that with me. I've never heard that or from my OBGYN.
Yeah.
But yeah, and so it also brings up another important aspect of supporting these patients and clients is that the psychosocial stressors can exacerbate a lot of their symptoms. And that's why
Yeah.
CBT, cognitive behavioral therapy, or other forms of psychotherapy can be helpful to give them that additional support. But that's also not enough. They need to have other people in their lives to support them. And at this point in life, women are also undergoing a unique set of stressors. They're usually mid-career. So there's those career demands. They're often in the sandwich generation where they're taking care of aging parents and children at the same time.
Absolutely.
Right. And women just carry a greater cognitive burden, all the unseen labor that women do in their families and around the home and so on. So it's important that we don't just attribute everything to hormones and that we look at bigger
No,
picture.
absolutely. And just to piggyback on that cognitive burden, I think because women carry so much of it, when they feel a difference in their cognition during the hormonal shifts, it's even harder for them, right? They've pushed themselves to the limit to be able to just make things work around them all the time. And then all of a sudden, they're not able to do those things. And they want to internalize it that I'm doing something wrong. Something's wrong. I'm doing something wrong. And so really helping them understand, like, this isn't a you thing. This is like normal of your journey and development through the hormonal changes helps them to just better understand and not internalize that conflict of not having the cognitive reserve that they used to have.
Sometimes when discussing nutrition or lifestyle interventions, it can feel frustrating to patients. I think sometimes they might feel like, oh, they're being blamed. I'm doing everything that I can do, or I just don't have time. I don't have time to make these nutritional changes, or to go outside for a walk. What are some pearls or some tips that you might have for the clinician in supporting those patients and clients to make the changes without the patient feeling blamed or shamed?
Yeah, it's a great question. And, what I've learned as I've talked to so many patients and women specifically is they've been gaslit a lot, right? With other maybe providers or in other situations. And so they're on the defense because they've had to be on the defense. And so I spend a lot of time just asking them first rather than saying, hey, you should do this. So I understand where they're coming from. And what I'm able to do then is to say, oh, that's interesting. Had you ever thought about this? And asking them first builds that rapport, builds that trust. Now, there are some women who can't hear it the first, second, third, maybe even like for 10 sessions, and it just takes them time, right? And other women who are able to hear it much sooner, but really meeting them where they are and say, could we make this little change? Oh, that change might. So, for example, if they're like, I can't go for a walk, like I'm with my kids, I'll say, have you thought about taking your kids for a walk? Maybe that would be really fun. Oh, I didn't know I could do that. It's like just sometimes I forget the simple thing, but I think for the nutrition piece, for the exercise piece, again, I do the same thing. It's really breaking it down to the bare bones, help them understand what little things we can change. But I also talk about what's going on inside our bodies, satiety, cravings. All of these are really complicated and like endocrine issues, right? They're based on hormones. And if we say this is a willpower issue or you just need to do this, it doesn't work that way. And so I talk a lot about if you've done all this and it's not working, something needs to change for change to happen. What do you think that's going to be? Do we use a lot of these motivational interviewing techniques, which if you haven't looked into, I think not you, but your viewers, but motivational interviewing can be so powerful to help patients feel empowered to make their own decisions and really feel like they're making the calls for their health versus us just telling them what to do. Because in one way, I'm saying, hey, you can't just trust the medical system. Educate yourself, research, ask the question. And then on the other side of it, I'm like, hey, listen to me. And you can't do that. Like, you really have to show up, I think, consistently. And so I tell patients like, hey, if you haven't read about the impact of sugar on your panic attack, because as your blood sugar changes, this is what's happening. And so really just trying to meet them where they are, I think is really important.
That's such an empowering approach, that collaborative approach,
Yeah.
patient-centered interviewing. So I have a video on that. So if anyone's interested in learning more about patient-centered interviewing techniques, you can check that out on this channel as well. But yeah, it's really empowering to give patients that information, to give them the resources. I'd love to hear if there are any specific resources that you refer your patients to. Are there any websites or books that you
Yeah.
recommend? But also helping them decide what they want to change in their lives versus us telling, oh, you should eat more protein or you should get more exercise. What do you
Yeah.
want to start with? What do you think? I call it
Yeah.
the low-hanging fruit. What's the low-hanging fruit in your life?
Absolutely. Yes. Yes. And I absolutely believe that. If you start with the hardest thing, they're going to feel like a failure, right? It's all these SMART goals, like what's going to be sustainable for them, but also feel like it's efficient and they're making successful choices that build confidence that allows them to do more and more. And I also will add to this, I think accountability is really important. And I know not every physician can do this, but I will have my patient, if they're doing, for example, their 5-minute walk a day, I will say for the next 5 days, I want you to message me after your walk. And for a lot of them, again, that it feels really like, first of all, someone cares about them, but that I'm accountable to her. Let me just do that. And I'll get messages saying, did the walk. I didn't think I would, but I did a 25-minute walk. And so there's this really engagement with that, which is, I think, really exciting. With regards to resources, I definitely, especially in psychiatry, recommend The Menopause Brain by Lisa Mosconi. I also tell patients to look at the Menopause Society for information there if they're in perimenopause and this is what they're looking at. I also ask them how they consume information because a lot of them are like, I'm on social media, that's what I want. So then I'll direct them to my page or my handle on Instagram, but I'll also tell them about some other really active accounts that could be helpful, like Mary Claire Haver, for example, who talked a lot about perimenopause. Louise Newson, who's in the UK, who does a lot about menopause and mental health. And then Rachel Rubin did a great podcast with Peter Attia. So if they're into a podcast, that was about women's health, and that's great. And actually, Mary Claire Haver also just came out with her own podcast called Unpause. And so really just making sure that it's based in data that they're getting information based in data rather than just going to like Reddit and hearing what other people are saying. And I always have this conversation that, like, if you have a question, ask me. If I don't know, I'll tell you I don't know, and we'll learn together. But when you just make the assumption, like a lot of women that come see me, they've made the assumption, like, hormones are bad. It will increase my risk of breast cancer. I'm not using it. That's the assumption. Okay, then you're basing your decision based on data that's not true. So for me, it's not about what my patient decides to do. It's that they have the education to make the decision that's right for them. And then some patients will say, I don't want to be on hormones. And so we say, okay, that's your decision, right? Or I don't want to be on an antidepressant. Okay, that's your decision. But then they're making it really in really evidence-based data. That's been really helpful. And I think that builds a lot of respect, mutual respect with patients, right? So they're like, okay, you're not forcing me to do anything. I'm not forcing you to do anything. We're just having this conversation so I can feel really educated in this space.
Earlier, you mentioned that clinicians just don't, like, I didn't get any training on perimenopause and menopause during my residency or fellowship. There was a little bit of mention about it, but that was about it. For those clinicians who don't have this additional training, what is one of the biggest mistakes that you see clinicians making? And again, this is not to blame anyone. It's just that we don't have the education. So what is one of the biggest clinical mistakes that you see?
Yeah, I would say in general, the biggest mistake is probably just not acknowledging that there's a hormonal change happening. It's really the basics of just, and again, I don't blame anyone for this either, but really just not acknowledging that perimenopause exists. And if you look at it, really 2 years ago, we weren't talking about perimenopause, right? This is a huge shift in culture that we're able to talk about it. But the reality is, like, hormones affect every person, men and women. And there are specific hormonal shifts that happen in a woman's lifetime. Every woman will go through perimenopause, menopause. I should say menopause, depending on if she's had a surgical menopause where she gets her uterus and ovaries taken out. The reality is that every woman will go through menopause. So if you're seeing any woman in your practice, you should understand what menopause is, what perimenopause is, and how it presents. So you can have a conversation, and then you can say, that's the limit of my knowledge here. I think you should see a specialist. But if you don't acknowledge it, I think that's where we make it's a huge disservice to women.
If you could leave clinicians with one takeaway today, what would that be?
Ooh, that's a good one. If I could leave them with one takeaway today, I would say don't recommend getting a lab test for menopause. I think it is such a common misconception and it's confusing women. Can I do two?
Sure, please.
And I would say mental health is absolutely affected in perimenopause. It is such a vulnerable piece and it often occurs before we see other symptoms. And so if you're seeing women in this, time in their lives and they're experiencing a new onset or an exacerbation of their symptoms, really helping them to understand that there's a hormonal element to this, I think is so important and hopefully become the standard of care of acknowledging in practice.
Where can people find more about you? What's your handle and website and all of your social links?
Yeah, of course. So my Instagram handle is at Dr. Harita Raja, and that's DrHaritaraja. I would say that's, or LinkedIn. I'm also on LinkedIn. It's my name there as well. And then I have an office website, but I don't think it's really necessary. Unless you're in the DMV area, we'd love to see you.
We'll put all of those links in the video description below, so go follow Dr. Raja on Instagram, and you can connect with her on LinkedIn as well. This was such an informative discussion, and I would love to invite you back at any time if you have the time and bandwidth to do so, to maybe even dig in more into the nutrition and exercise piece, because I think those are areas that as clinicians we can recommend to most all of our patients, right? Even if you're not prescribing hormone replacement therapy. And there are some nuances with protein intake and with strength training and things like that for women that not only benefit mental health, but also sleep. So open invitation, but thank you so much.
Absolutely. Thank you. Thank you so much for having me. I look forward to seeing you again.